Hi, Jen.
Hi, Bethany. I cannot contain my excitement for the guest we have today. She is someone whose voice I've spent many hours listening to in my car on my way to work, and I just cannot wait to speak with her. Today we are chatting with Kayleigh Summers, aka the Birth Trauma Mama. Kayleigh is a licensed therapist who specializes in perinatal mental health and is herself a birth trauma survivor. She's built an incredible community for birth trauma survivors through both her podcast and social media, and has helped so many women feel seen and validated by compassionately sharing their stories. What really sets her apart for me is how she's taken things a step further by actively engaging with healthcare providers, which is so needed for us to really see change for moms in their birth experiences. She also speaks about provider trauma, which I so appreciate and can attest is a real thing. I started listening to her show, the Birth Trauma Mama podcast, a couple of years ago, and has given me many ideas on how to improve my practice and take care of patients in a more trauma-informed way. Her journey to doing all these wonderful things in the world of perinatal trauma began after she survived an amniotic fluid embolism, also known as an AFE, during her son's birth in 2019. We came here today to discuss the intersection of birth trauma and C-sections, but we are going to start the show a little differently than we had planned. And that is because of the recent tragic loss of Hailey Okula, a fellow healthcare worker. She was a nurse and a nurse educator as well, who died from an amniotic fluid embolism shortly after giving birth to her son. So Kaylee, we just want to open it up to you to say whatever it is that's on your mind, and welcome to the show.
Yeah, thank you so much for such a warm introduction. I truly appreciate it. I'm so grateful to get to be here and do this work. And it's been a really, really heavy couple of weeks. I'm devastated for Hailey and her family, especially her son crew. And this stuff is hard. Being in the amniotic fluid embolism community means being in a world of grief and in a world of devastation, because these events are catastrophic, and it's not fair that we keep losing moms and babies, and it's not fair that some of us get to survive and some don't, and we still don't know why. And I'm going to talk, of course, a little bit about my story today, and there are other grieving families who have lost loved ones, and there are other families who have experienced an AFE and have survived. And something that I want to make very clear to those who are listening, because I get this question a lot, I've gotten this question a lot recently, is kind of why? I actually had someone say, why wasn't her team prepared? And that is not, I want to put that to rest. I raise awareness because teams being prepared is the only chance that we have, but it's only a chance when it comes to AFE. So you can have the most prepared team with the most resources at the highest functioning academic medical center, and you could still, unfortunately, not survive an amniotic fluid embolism. They can do everything right, everything perfectly, and the chances are still up in the air. The survival rate right now amongst the research ranges from about 20 to 60%. So what I like to say is, even when you have everything in your favor, when you are at a state-of-the-art institution with the best minds, with the best equipment, you still only have a 60% chance at surviving an amniotic fluid embolism. And so I have a hard time, right, talking about my context of surviving in this arena right now, because so many don't get to. And my team will be the first to tell you that, of course, they made a lot of right decisions, and they also got lucky. The first step is providing awareness and preparation and drills and simulations so that people are prepared. And even when people are prepared, this is such a catastrophic complication that we don't know what the outcome is going to be.
I think that's so important that you are bringing light to that, because it is hard when something traumatic happens. Of course, everybody wants to blame someone, right? I mean, that's just human nature, especially for families. It's like, where do you even begin starting to heal when the most natural thing is to say, who took this human from us so unfairly?
Of course. Especially we get the kind of, and I know you will probably be able to relate to this, we get that, how are people dying of childbirth in 2025? So something must have gone wrong, been done wrong, etc. Because no one has ever heard of an amniotic fluid embolism until it impacts you.
Right. That's so true. I also think too, it's hard about a conversation like this is for you supporting women through trauma, how this event probably restirred up so much past trauma for you as well. How do you continue to heal when you're so involved in this community?
Yeah, that's such a good question. It's a hard one to answer. I feel really strongly. I have this sense of not centering myself in someone else's tragic loss. So I am totally allowed to have my feelings and what comes up for me. But as someone who just is so public about talking about AFE, I have a hard time with questions like this because I know all of the families that are suffering, and they are the reason I do this work. They are the reason that I show up every day. And so while I will continue to be devastated every time we hear about a loss and we are supporting a family through a loss due to amniotic fluid embolism, it is also the reason that I continue to wake up each day and talk about this. It's the reason that I continue to share my story, because not only did I survive an AFE, but I survived with no cognitive impairments. I survived in a way that allows me the advantage to be able to do this work. And that is something that I will not ever take for granted. And so I didn't really answer your question. I have my own therapist. I will always be working with that therapist to talk through this stuff. I have friends that are amniotic fluid embolism survivors. We have a great community. I have a fantastically supportive family and friend group. And so I will take care of myself, because the only way that I can continue to do this work is if I take care of myself.
100%.
I know some people in your community have mentioned too, for people who are pregnant right now and they're hearing about this news and it's bringing up all kinds of feelings for them, what would you say to them if they're now suddenly super anxious and nervous about something like this happening to them?
Yeah, I would say your anxiety is valid. You get to be anxious. You get to feel this way. This is anxiety provoking, and I can't take that away from people. And talking about how rare it is, it's 1 in 40,000. You are more at risk on your drive to the hospital than you would be having an amniotic fluid embolism in labor. That doesn't make people feel better. And I deeply understand that as someone who is a rare statistic. And so what we can do is obviously get the support you need. If you're having incredible health anxiety, like reach out to a therapist, get support during your pregnancy. And the other thing is ask your providers about it. Ask your providers about, hey, I saw this news article. I'm feeling incredibly anxious about an amniotic fluid embolism or any other sort of like catastrophic thing. What should I do about that? And some providers will brush you off and say, well, that'll never happen. And if they do that, I really recommend you say, I hear you and I appreciate you trying to reassure me, but that actually doesn't make me feel better. What would make me feel better is if you could tell me what your protocols are. If you have someone who has a maternal code, do you guys do drills for maternal codes? Are you ACLS certified? Is your team ACLS certified? Take me through what happens with a massive transfusion. What does your MTP look like? These are all questions that you have every right to ask your team when you are the one delivering. You are allowed to be anxious and you are allowed to prepare. I also had someone write in when I answered this question, reminding others that it could be helpful to create a contingency plan. So we talk about birth plans a lot, and this would be more of like a contingency plan if things don't go to plan. So if you are intubated in an ICU, what do you want to be happening? If you are in a C-section and things start to turn south and the baby has already been delivered, do you want your partner, if you have one, to go with the baby, to stay with you? Do you want to use formula if you're not able to be there and breastfeed? Do you want to use donor milk? All of these things that hopefully you will never need. But this person reminded me, it can make you feel like you have a lot more control in a situation that is going to be very out of control if something catastrophic were to happen.
Yeah, I think that is so important, because a lot of what we talk about is control the things that you can control, and information and asking questions truly does give you that control back, and also for your partner to feel a sense of control as well, because yes, it's our body and it's happening to us, but they're the ones watching everything unfold, and it can they can feel so out of control on how can they support you best if you don't have those earlier conversations for how you want to be supported in a moment.
Absolutely. Absolutely.
It also makes me think about the partner's trauma too in situations. How do we best support a partner in a situation where they're now left with these memories? And what is that advice that you help the community see on really supporting them as well?
I think talking about partner trauma is the first step, talking about it even being a thing, because I don't think it's been talked about until recently. And we have tons of partners who are traumatized by the events that occur. I think one of the hardest things is getting partners to recognize that they might be traumatized.
Yeah.
And so we can't force people
Right.
to get therapy, but we can encourage, we can let them know that it's okay if they were impacted by this. There's a lot of, I don't deserve to take up space because it didn't happen to me. And while I understand and can empathize with that and love the goal of giving all of the support to your partner who you feel like has experienced this physically and emotionally, you have also experienced it emotionally. And I will suggest sometimes a good way to introduce a partner who may be just nervous about the idea of therapy, maybe a little resistant, to invite them into your own therapy. I do that a lot with clients because it can actually just be helpful for me to, it's not couples therapy, but for me to help that partner understand where my client is feeling unheard, unseen, etc. And usually what happens is the dynamic of their own trauma comes up in that session. And it also like demystifies therapy for someone who's never been in it before and might be a little nervous about it.
Yeah.
I like what you said about asking questions of your own OB team if you're worried about some kind of catastrophic event, because it reminds me, we discuss things about the babies, know your level of NICU or know the closest higher level NICU should anything go wrong. And I think we've missed that part of it, where know where you stand too, as far as what's available to you in your medical care if you are needing a higher level of care as well. So that's super important. Just talking about birth trauma in general, can you just start off with a definition, and how might someone know if something that they experienced falls into this category of birth trauma?
Yeah, of course. So the definition that I like to typically use for birth, so when we talk about birth trauma, we're really talking about perinatal trauma.
Yes.
Mm-hmm. At least I am. And perinatal trauma is
we thank you for that.
it's fine. I'm literally called the birth trauma mama. And I have people ask questions all the time like, hey, does this count if it happened during pregnancy? Does this count if it was actually, my hemorrhage was in postpartum?
Yeah.
And the reason we use birth trauma is because it's actually taken off. People know what birth trauma is. They talk about it now. And perinatal is just a bit more of a clinical term. But perinatal trauma is kind of the umbrella term that includes the reproductive trauma, pregnancy, birth, postpartum, any trauma that happens in that period. And so the definition that I use is any kind of threat or situation that overwhelms the nervous system's ability to cope and causes ongoing distress within that perinatal period.
So is this something that someone would recognize? Let's say something happens to them, they have some kind of complication, something bad. Will they understand always initially that they've experienced something traumatic? Or do you see sometimes where people will really have that feeling of being very grateful, I'm alive, my baby's alive, and really believe that for a long time, and then maybe later on they realize that actually no, this was traumatic to them in some way?
For sure. I see that very often. There's this like high, this is actually something I experienced as well. There's like this high of gratitude in certain situations of trauma that eventually starts to fade away when we recognize the impact that the trauma has had on our nervous system. But when we look at perinatal trauma, there's many thousands of different causes, right? Because it's a subjective experience. So it depends on your nervous system, your experience in that moment, whether you experience trauma or not. And that's going to be different than someone else in the same exact situation as you. And so we really can't compare trauma. But in these kind of thousands of different ways that trauma can occur, we typically see it fall into two broad general categories, which are threat or perceived threat to the life or safety of the pregnant person or the baby, and then treatment provided by the team. So harm caused by a team. We see that often referred to as obstetric violence or mistreatment. Those are kind of the two very broad categories that we see within the perinatal trauma space. So one's more relational.
So would you say, if we're looking at how we could possibly, if any of these are preventable in any way, would you say the latter category would be the one obviously to focus on?
So I think a lot of things. Okay. So when I speak about, like, to nurses, to L&D teams about perinatal trauma, I talk about prevention and mitigation.
Yeah.
Because for us, I don't want people to think that someone who experiences a severe maternal event, they're going to be traumatized and it's hopeless. There's so much that we can do to mitigate that trauma. And then there are experiences like in between. And by that, I mean something that doesn't go to plan, something that is maybe a little bit urgent, an unplanned cesarean. And the way that we show up and explain that can be the difference between trauma and not. I'll give an example of like an unplanned C-section, and a patient is really upset. And the nurse approaches that patient, or the OB approaches that patient and is like, why are you upset? C-sections happen all the time. It's no big deal. That is meant to be reassuring. That is meant in good faith. I 1000% believe that. But that is actually going to be harmful, as opposed to saying, hey, I hear you. It makes so much sense that you're upset. You didn't expect this. This wasn't your plan. And I totally get that. We are going to do everything that we can to still be able to have X, Y, and Z that you wanted in your birth plan, to try to do skin to skin right away, to try to have a clear drip, whatever it is, but acknowledging that that person has every right to feel upset about the fact that their birth isn't going the way that they want it to.
Well, it's like so much of like what we say, and when somebody perceives their own thoughts onto us, it's like, are you discounting what I'm saying right now? And I think that that can be the most frustrating thing when you maybe you don't know the magnitude of the trauma that you've experienced until some time has gone by, but it's already like, nobody wants to hear your opinion. I just want you to understand my feelings and validate them.
Yeah,
exactly. Exactly.
Our last episode was about, we just asked everyone things that they will never forget that someone said to them during the course of their birth. And when you really look at, they're all different, but when you really look at them, it's the difference between something that's validating and whether good or bad. The good ones were validating them, and the bad ones were invalidating them. Right. They're like just not accepting their feelings or brushing them off in some way.
I'd also say too, and I'm sure you probably feel this way too, I think when you've experienced trauma, you are rewired in a different way. You are now a different human, and you kind of look at the world in a different way. And I know when I went through trauma, the things I would never have thought I would have remembered, like the 2 words, whatever it was, it is wild how our brains really attach to things in a different way when you're in a different place emotionally.
Absolutely. Yeah, absolutely. And the vulnerability of birth plays into that.
What are some signs or symptoms when it comes to when your brain experiences this trauma? How does that present symptomatically afterwards? What might people experience? What did you experience when you started to realize that what you went through, you needed to work through that?
Yeah, so I think for a lot of people, there's a wide range of experiences. The typical that we see with a typical PTSD diagnosis, you're going to hear about flashbacks and nightmares, like all of the kind of typical things. But with perinatal trauma, I see a lot of rumination, a lot of going back over the experience and trying to figure out how it could have changed, how it could have changed, how it could have changed, how it could have changed. A lot of what ifs, a lot of what if I would have done this, what if the doctors would have done this, and taking up a ton of brain space, ruminating. And then we also see that nervous system activation around certain, so that's what people refer to as triggers, which is just a bit overused. So I try not to use that word, but this nervous system activation related to reminders of the trauma, because again, when we think about trauma, we have to remember that trauma doesn't act as a memory. It acts as a present experience. So every time that traumatic memory, quote unquote, gets activated, your nervous system feels like it's happening right now. And so we actually see this, and it's one of my favorite studies to talk about because I think it depicts it so well. In 2023, they did a study looking at people who were diagnosed with PTSD And they had them record themselves saying a happy memory, a neutral memory, a sad memory, and a traumatic memory. And then they played it back to them while they imaged their brain. And what they found was for the happy, neutral, sad memories, unsurprisingly, the hippocampus was activated. For simplicity's sake, basically the memory center. And then when they played back the traumatic memories, the hippocampus was not activated. And instead, something called the posterior cingulate cortex was activated, which is essentially related to like daydreaming and internal processing, which again shows us that trauma doesn't act as a typical memory. Because during a trauma, don't get me started too far on this. I'll go down
I love it.
But I'll just tell you that during a trauma, the hippocampus, during the actual event itself, because the amygdala kind of takes over the fight, flight, freeze, fawn, shut down, all of that automatic response that we don't get a say in, that we don't get a choice in, that responds to the threat, it takes over the system. And so the hippocampus is not activated. And so the hippocampus doesn't do its typical role of saying like, hey, like big stamp from the library, this event happened in the past. And so we don't get that context, and that memory gets stuck in our system exactly as it is. And it doesn't get the tag of being in the past. It also doesn't get the ending, because it gets stuck in a fragmented way. So the best example I can give for this is like when people deliver a baby, and at any point there was a threat to the baby's life, whether actual perceived, doesn't matter. They thought their baby wasn't going to make it, and that gets processed as trauma. It gets processed exactly as that, without the ending that their baby ended up being okay. So every time that trauma gets activated, their nervous system believes that their baby is not going to survive. So we're talking like cold, like they have a cold with a runny nose. That mom's cognitive part of her brain knows they just have a cold from daycare, no big deal. But their nervous system is like, oh my God, they're going to die.
That's so wild. Interesting. Yeah. I think that's like when mothers respond, they're like, oh my God, what's wrong? People are like, everything's fine. You're like, no, my response was not, I didn't think through how animated I was going to get. And when they just cut their finger a little bit, it's just within us. And that is, having that clarity is really amazing.
If you have this experience kind of, it seems, stored in the wrong place of your brain, how can we fix that? What can we do? And can we move it back to where it belongs as a memory?
Yes. We can heal from trauma. That's the best part about trauma, is that we can heal from it. And the way to do that is through integration. We've got to integrate that memory back in with its appropriate ending, and also with what we call more adaptive information. And so typically trauma is stuck with information that is, we call them kind of like negative cognitions or negative self-beliefs. Every trauma that we have, what makes it, I say this, sticky kind of, is that there's a negative self-belief attached to it. So in the perinatal space, we see a whole lot of my body failed my baby, my body failed me, I can't handle this, I'm not good enough, I'm a bad mom, on and on the list goes. And so we have to reintegrate that memory, again, with its ending, with the idea that it happened in the past, and with more adaptive information. I did the best I could with the information I had at the time. My body did the best it could to X, Y, and Z. The way that we do that is through a bottom-up approach to therapy. So more somatically based, body-based approaches, EMDR, brain spotting, internal family systems, somatic experiencing. There's lots of different options, but definitely an option that is a bottom-up approach rather than a talk or cognitive approach, because we can't quite access the part of the brain that we need to in order to reintegrate those memories when we just talk about it.
That is so interesting.
Yeah. I'm just thinking about that separate piece of it that's maybe making it sticky. And speaking about C-sections, one of our missions is reducing stigma and shame around C-sections. There are all these complicated feelings that come with C-section births. I was wondering if you think any of this cultural stigma that we have, if someone's experienced that, if that is affecting how they end up processing an event and if it makes it more traumatic for them.
100%. Our beliefs about birth and our bodies and what our bodies were quote unquote made to do, 1000% impacts our processing of our birth experience. That's also why it's subjective, right? Because some people will have a much different idea or experience going into birth than other people. Like the C-section part of my experience, I was like, destined to have a C-section. That's how I felt. Like I was like, my mom had 2 C-sections. I knew I had a really big baby. Once I got to 10 centimeters, he was sunny side up.
All the things.
He ended up being 10-14. He was massive. So like, regardless of the whole like perimortem aspect of my C-section, there was going to be a C-section. So I don't have a whole lot of feeling about having a C-section, but someone else who has a much different experience of what they want their birth to look like, of what they believe their birth will look like, of what their families, friends' births have looked like, will have a much different experience of that. And the societal pressure around that absolutely will impact how someone feels about their birth experience.
And particularly if they've been planning for their entire pregnancy, trying so hard for this goal of a birth looking a certain way, that has to, when it doesn't go that way, that has to have some effect.
Oh, for sure.
It makes you think that, you know, some things that people say can end up being harmful.
Oh yeah.
There's this big push, which I think is appropriate, for reducing C-section rates and unnecessary and unwanted, both. Yes. And that is important, but I think all we've been talking about when it comes to C-sections, we sort of need to acknowledge a lot of people have C-sections that are very valid medically or of their own choosing, and supporting those people and focusing on how we can improve recovery or how we can improve the birth experience itself.
There can be such a positivity aspect to it when it's the best choice for the mom and for the baby. Period.
Yes.
It's interesting. Sometimes we'll like ask people what their birth plan is, and they seem hesitant if they want to say they want to have a C-section because they don't want to hear other people's opinions. And I think that bringing to light that you should be able to say whatever birth, or don't say it at all, right? Is it anyone's business? But if they do ask, to feel proud in the decision that you're making because it's the decision that's best for you.
Yeah, it's asking us to hold 2 things at the same time that are conflicting, which is that we absolutely need to work on our C-section rates for unnecessary or medically coerced C-sections.
Well, definitely,
100%. But we need to be able to hold that at the same time as allowing people to make autonomous decisions about how they're going to give birth. I had a bit of like a back and forth with someone in my comment section last C-section awareness month, who's like this huge advocate for informed consent and autonomy. And the research shows that the people who are at the most risk for developing a perinatal mental health condition post their delivery, when we're comparing a bunch of groups of people who wanted a specific birth and didn't get it, a specific mode of delivery, the group that is at risk the most within those groups is the person who wanted a C-section and instead was forced to deliver vaginally. So even more so than someone who wanted a vaginal delivery and had a crash C-section. Because think about the reasons that someone would choose a primary C-section. So trauma, especially sexual trauma.
Yeah.
There's so many different reasons. I've had people who have tocophobia who have also chosen a C-section. And so this person was saying that's such a big risk. Like they don't understand how big of a risk that is. That's not a good enough reason, essentially. And I was like, what?
That's like nails on the chalkboard for us. It's not a good enough reason. Oh.
And like this idea of like you push informed consent so much, you push autonomy and patient autonomy so much. This is the same thing. You have to be able to provide it both ways.
Yes. And I think, you know, just the examples that you mentioned, the problem is a lot of times when people are electing a C-section, they're for deeply personal reasons and maybe things that are hard to talk about.
True.
And so you don't have those people out there defending themselves because they are really personal, complicated feelings and thoughts that they have about things, but they know it's the right choice for them. And I see this with patients too. I always see when I'm going into consent a patient for a C-section, what's the indication for the C-section? And I kind of, you know, okay, this makes sense or doesn't make sense. And whenever I see one that sometimes I feel like people kind of make up a reason and I'll speak to the medical team and the OBs and, well, I don't understand. This doesn't really require a C-section. But then I go talk to the patient and then I can always see there is something more
Yep.
I mean, they almost don't feel like they can say it as their reason, and they don't need a reason, but I just always know, oh, this makes sense. Perfect. Fine. It's because she wants it. This is the choice for her. Great. Fine. Like that's a reason. And I also, when we've talked about this before, I always mention that ACOG says right in black and white that it is okay for women to choose this, because it's been shown that people have valid reasons. And that is exactly part of patient autonomy, to be able to choose that and to trust women to know that about themselves, that they, for whatever reason, this is the safest, it feels the safest to them.
Yeah,
absolutely. And we see it as a really common choice after birth trauma, especially birth trauma that involved. Because there is so there's kind of like two camps, right? The one who's like desperate for feedback and that kind of like healing experience that they believe that will be, and for some, of course, it is. And then people who are like, I want to be able to control this a heck of a lot more, and that will give me sort of peace of mind, and I'm going to go with another C-section. So we do see that a lot in the birth trauma community. And we also see it a lot. There's this interesting group of people who have had severe lacerations. I don't know if you've heard of the Solace Foundation. They're amazing. They're like a new foundation in the US that is for OASI. And I talk to them a lot, and something that will get said to them is, well, at least you didn't have a C-section.
Oh no.
And they're like, I would have killed for a C-section if that was the alternative. So there's just like, my point is there's so much nuance in this space. And what becomes really difficult about it is that with that nuance, when you're talking about my community, there's also so much trauma. And it's really difficult to see outside of your own trauma, especially in those early days. So a lot of people can't understand why someone would not choose a VBAC, and the other side can't understand why someone would ever choose that. I get the question all the time, like, oh, so are you super against home birth then, since you had an AFE? And I'm like, I'm actually just not against anything. I'm not choosing that for me. What I would choose for me is not what someone else would choose for them, because just as I would choose a hospital for me, if I had the opportunity, if I had a uterus to be able to have another child, I would choose the highest level hospital with ECMO, all of those things, because of my traumatic experience. The other person who's been completely abused by the system, who has been treated horribly by medical providers, of course would never want to birth within the medical system again. That makes so much sense when we look at it from the trauma lens.
It's like respecting the gray area, in life. Some people are like so much wanting like the black and white. That is not life. That is definitely not birth. That is definitely not motherhood. Like everything is gray in motherhood.
Yes, absolutely.
Really Can I ask you a personal question as a mom?
Personal questions.
How did it feel to connect with Cal after you had, you are obviously a fighter, you're a survivor, but how you saw yourself as a mother before this experience shifted everything?
Yeah. So I was in a medically induced coma for 5 days. And so I did not meet Cal until 6 days after his birth. And I don't remember that. We do have like videos and pictures of it, but I unfortunately don't remember it. And it took me a very long time to bond with him. I remember, so this is something that people really, I did not realize how much it would resonate, because it's such a weird thing. And I was a little afraid to talk about it when I first did a few years ago. I didn't think that he was my baby. And that can sometimes happen with being like under general anesthesia, or again, in my case, I just like wasn't technically alive when he was born. And so I really like didn't think he was my child. I was like worried that he had gotten switched. Of course, that's like highly unlikely. But your brain does all of this kind of weird stuff. When I got home, I couldn't take care of him, unfortunately, because of how big he was.
Do you mean physically you couldn't? Because you just had all these surgeries and...
Yeah, so I had 5 abdominal surgeries in 4 days, and like a bunch of chest tubes, like all of that stuff. But mostly the issue was that because he was so big, I wasn't allowed to lift anything more than 10 pounds. And he was more than 10 pounds.
Yeah.
And so I actually wasn't allowed to pick up my own child for the first 6 weeks. So my parents lived with us and helped us take care of him, which was just like trauma soup, because they were there when everything happened. They were traumatized. My husband was traumatized, and we're all trying to like figure out how to live together and take care of a baby. So I probably didn't bond with Cal until about 6 months postpartum. And what I wish that I would have known at the time, and I wish my family would have known at the time, is that delayed bonding is completely normal after an experience like this, because that would have given us a little bit of relief. It wasn't the delayed bonding, it was that I felt like a monster, because I will take care of my child when I'm physically able to, but like, this is not what I had expected. Absolutely not.
But that's so brave of you to say that. It's making somebody else who's experiencing or might have experienced the same feelings feel like I was actually processing this in a normal way versus I wasn't being that emotional mom and connecting. And again, it's like all these kind of like the second your baby comes out, it's like you should have this instant bonding session. That is not the case for most women, but we don't want to say it out loud.
I was just going to say, bonding in general, even without trauma, is a thing. You know, it's something that doesn't happen right away. Yeah. It's a thing that we sort of work towards, but it's not so automatic for a lot of people, basically.
Yeah, exactly. And after trauma, it's interesting because it does kind of go two ways. That follows our reaction to trauma, which is, and I didn't really cover this when we were talking about symptoms, and I probably should have, but typically when our nervous system is traumatized, we have a hyper-vigilant response or a hypo-vigilant response, hyper-arousal or hypo-arousal. And you can flip back and forth. You don't have to like be in one, but the difference in that experience, I also see tracks with bonding. So hypervigilant and hyper-aroused is what we see with someone who's like really anxious. And they're like, is the baby breathing? Is the baby breathing? Is everything okay? Is everything okay? Is everything? And we see that with postpartum anxiety without trauma too, but we really see it after trauma. And then the hypo-aroused, which was definitely me, which is more of like the numbed out, dissociated, depressed type of feeling. Again, you can kind of flip back and forth, but we see that with bonding. So delayed bonding is getting a lot more traction, I think. Like we're talking about it more, and we're talking about it more in the context of trauma. But I see lots of clients who cannot let anyone else even like hold their baby. And I want to be clear, there's kind of a continuum of normal here. You had that baby inside of you for 9 months. Yeah. You get to tell you get to tell people. But when that client is coming to me and saying like, this is out of control, I can't function, right? Because I can't leave my baby for more than a minute. I can't sleep because I'm constantly checking the monitor because I feel like they're not going to be breathing. So there is this hyper vigilant bond that can also happen in the beginning stages versus, again, that delayed bonding that I and some others have experienced too.
Is there any definition for delayed bonding? I love number, but like, is it, after a certain amount of time, or is it such a subjective thing that it's just sort of a concept?
That's a good question.
I don't know.
It's a really good question. I actually don't know the answer to that. I don't know if in the research there is like a definitive time period that would be like, oh, you have entered
within the range of normal or something.
Yeah. I don't know, but I would say after the first, I'm going to arbitrarily say like, if after the first like month, as things start to settle in, you still aren't feeling connected with your baby, I would get curious about it. It also I don't know, it just support and therapy, but also like, it's like, there's nothing to do except for get the treatment that you need.
Yeah. And certainly don't blame yourself, basically. It's
not. This is a normal reaction to an extraordinary experience, is what I like to say.
That's a great sentence. That's the thing, having your safe people and your mom friends is so important. And I talk a lot about the unwelcomed guests and the unwelcome comments and the there's something that is so important about even that friend who just comes over and just doesn't say anything is sometimes the best friend in that moment, because sometimes so much is going on in your own head. You just can't have other noise interrupting that.
Exactly. I couldn't agree more.
Speaking of bonding, so it's something that I think we all want, right? We all want to bond with our children. And when I've read about certain things that may improve bonding, so things like early skin to skin.
Yes.
How beneficial are those type of things for how people process their birth and how they bond with their children? If we make more of an effort in healthcare to look at bonding as like an outcome that we're hoping for, I guess,
I have a lot to say about that.
Okay.
I don't want to overstate the importance of skin to skin, but I will, because skin to skin saved my life. And I know that every medical machine under the sun, my entire medical team saved my life. I have no doubt about that. ECMO, Impella, like it saved my life. The choices that were made, the decisions that were made, the way they were made saved my life. And I went from a situation where my heart was not functioning anymore. I was on ECMO, it was keeping me alive. My heart was not functioning anymore. And so they had placed an Impella and said it was a last ditch effort and we'll kind of like see what happens. But they got my son into the CTICU skin to skin within 24 hours. I was still on ECMO when my son was placed on my chest for the first time. And they continued to bring him in every day, twice a day for skin to skin. And I actually had one of my CTICU nurses reach out to me recently, and because I had talked about it recently, and she was like, I just remember, she's like, your stats would totally change. Wow. She's like, your stats were incredible. And in 2.5 days, so 2.5 days from my AFE, I was supposed to be on ECMO for at least 2 weeks. 2.5 days, I was removed completely from ECMO and Impella support.
Wait, this is insane. I knew this part of your story, but I didn't know that part about how they actually would see how it was affecting you. Because I thought you had talked about how there was a piece of it when you look back at photos, I think, that it was, you weren't there, right? It was kind of, the decision was made for you, but it sounds like you are so beyond
I think you're talking about breastfeeding.
Oh,
you're talking about...
Oh, did they like pump you?
So they pumped me.
That's what it was.
Which is a whole nother conversation they made the best choices for me at the time. And I still feel like a little icky about it, but that's no one's fault.
But
no, not skin to skin. Skin to skin, I am so, oh my God, and so beyond grateful.
You know what? Like that is actually insane, because just thinking, and thankfully I haven't had a patient in your situation, but I've had patients in the ICU for a couple of days and they don't see that baby until they're out of the ICU. And they
fight so hard for this.
A lot of times, you know, when they're kind of ready to come out of the ICU, the patients, they just want to get out of the ICU so they can go see their baby for the first time. Was he in the NICU or was he in the...
Okay, so here is where things do change.
Okay.
And I want people to be aware of this. I was very lucky, very, very lucky. For some reason, I have no idea why. Probably my team was able to get him out from 6 minutes from the code call until he was delivered. That was it, 6 minutes. Still, that's a good amount of time without oxygen.
Right.
And he needed to be resuscitated, but for some reason he did not need to be cooled. His APGARs, just like very quickly, babies are resilient is what I've been told, which is amazing. So he was only in the NICU for 1 day. Babies that are in the NICU, and often with AFEs, babies who are still in utero will be in the NICU being cooled. So they can obviously not be brought down to the ICU. But we do also have babies who are born and then the AFE happens. And we also have other situations like you're talking about, like hemorrhages and things. Exactly. So I just feel so strongly that in almost every case where the baby is fine and not in the NICU, the risks do not outweigh the benefits. Everyone freaks out about bringing a newborn into the ICU. And while I totally get that, I really do understand the risk of that. I don't want to downplay that at all. I also think we're not giving enough weight to the benefit that this could have for a critically ill patient.
So amazing, because we talk about it the other way around, how it's good for NICU babies to have the skin to skin. It's good for moms too.
But it is. That's kind of what they told my husband, who my sweet husband was like, so you're not going to put an 11-pound baby on her chest while she's on life support. And they were like, this isn't just for the baby. This is for Kaylee too.
Wow. That's incredible. Yeah. Had they ever done anything like that before? How did they know to do that? I have a lot more questions now. Do you know, did one person have this great idea and everyone was on board? Were there systems in place?
My CTICU nurses fought very hard to make sure that it happened. Again, there were a lot of things that were done for me that I'm very grateful for. And I think there were a lot of things that maybe are not protocol. My husband slept in the cardiothoracic ICU room every night. I know people are not usually allowed to stay in ICU rooms. And they ambulanced him to my hospital, not because he needed treatment there. He was fine. He could have been discharged. They did a compassionate transfer to transfer my kid to the hospital I was at, and then they boarded him for 2 full weeks. so that they could bring him down to the ICU every single day once I was conscious too, so that I could like hold my baby and feed my baby, do everything. Again, I know that's not always possible. I know the thing, but
it
just
should
to put
be,
that,
honestly.
I know.
Why not?
Right.
You know?
Right.
And when you hear examples, whenever you hear someone else was able to do this, it kind of lights a fire under you of why can't we do this for everyone in this type of situation? And it just makes you wonder, it seems, received not only really good medical care, but really compassionate care.
Yes.
And look at
That is
your
what
outcome.
I always talk about.
And you had a, ultimately, like you said, without the neurologic deficits, I mean, you're here, you're talking to us, you have to wonder, this is why we need to include that aspect of care, because how much does that affect
100%.
how people actually come out physically from these type of things? It's really, really incredible.
Could not agree more. I always talk about not only the life-saving medical care, but also like the compassion and empathy. My debrief was amazing. My OB and my anesthesiologist from my initial code from my hospital came to Lankenau, where I was at, and sat with me on either side of my bed. It's my first memory that I have.
I love your everyone on your team. It's really great.
Have you listened to the podcast with my OB?
Yes, I did.
Amazing. Yeah, she's amazing. I love her.
Yeah, and all the other surgeons that were involved. It just seemed.
Yeah,
but
they were awesome.
But yeah, it's like everyone deserves that type of care, especially people who have had a complication, some medical event. They especially deserve that kind of care. And I kind of see it that way with a C-section. I mean, they're having a surgery. Let's give them all the things that we can as far as the compassion and the promotion of bonding and all of that.
Absolutely.
One other question I had for you is about sharing birth stories, since I know a lot of your podcast you have a lot of things on there now, but one thing is sharing, people coming on and sharing their stories. Is there any evidence that storytelling, sharing your birth story can help you heal from trauma?
Yeah, I think first of all, like narrative therapy is an approach that is done obviously like in the therapy room, but it's related to storytelling.
You kind of write out your story.
Yeah, it's related to storytelling. It's related to like changing the narrative of how your brain processed the story as trauma. And so I won't kind of get too far into that, but so there is absolutely some evidence to point to that it could be helpful. I don't know the actual research on birth story sharing in this way, where you're kind of just like talking about it and sharing it out to the community. The response that I get is that it feels good because it's like purposeful, and it's a way to spread either awareness about like a specific complication that person experienced, or just awareness about birth trauma in general. Because the one thing I will always say is the point of my space, right? So people are like, well, if pregnant people come across it, they're so scared. And I'm like, I hear you. It's not really maybe the place for pregnant people to like hang out and swim in. However, it is a place for pregnant people to say, hey, this is something that can happen, so that when you get on the other side of your birth experience, if you are traumatized, you know you are not alone. Yeah. You know you can get support, you know you can heal, and there's a place that you can go. That is the goal in terms of people knowing that our space exists when they are pregnant.
Actually, so when Jen and I first talked about having a podcast, she was like, have you ever listened to one? I was like, no, I actually haven't. She's
any
like,
podcast.
You probably should. And I was like, okay. And actually, of course, the first thing I went to was something about birth, because that's what I'm passionate about. Totally. And then I started, you were the first podcast I'd actually ever listened to, because I found it so therapeutic to really listen to other people's stories. And even though I had already had a child at the time, it's like there are pieces of it that can filter and make you feel like, oh, wow, that was something I experienced too. And maybe it isn't the exact story, but it sure comforted me in so many different ways.
Oh, thank you for saying that. It doesn't have to be the exact story. And we've seen that a lot. It's really about the impact. We connect over the impact that these experiences have had on us. And so there's almost like a little kernel or nugget that you can take from each story, even if it doesn't fully align with yours.
For sure.
So I have one final question for you. What is the one or couple most important changes that you would like to see in the birth world? I know this is really a lofty one, whether it's in hospitals and culture that would better support, let's say, C-section moms or moms any moms giving birth.
Yes.
I know. Just pick one.
Jen came at you with a very loaded question.
So I have so many. Okay.
I know.
I'm gonna make sure like one or two. But the first is the acknowledgement and support and treatment of provider trauma. And the reason for that is because one, providers are humans, healthcare workers are humans. They deserve support for the massive amounts of trauma they've been through. And also, I would argue that a large percentage of perinatal trauma would not happen if provider trauma, healthcare worker trauma was treated and managed. And I also know that that is like a top-down approach that needs to happen within our medical system that is very, very, very broken right now.
Can I say something on that really quickly? Yeah. So something that I've had to do as my own personal way of combating that, aside from obviously therapy, which therapy for everything, but I had to change my work schedule, aka not work as much, because I saw that at some point this is I'm going to lose my empathy. I'm going to lose what I try to give, and I can't give myself all the time for so many hours, day after day after day. I have to break it up a little bit. And for me, that was the path forward. So until just something as simple as that, making work hours reasonable, also allowing time for reflection after we have a bad day, after we experience things, and not have to get up and kind of do it again all over again. And I know you've talked about all kinds of things related to that as far as us getting actual time to debrief immediately after things happen.
Do you know what my approach would be? What if every doctor and nurse got some like Reiki session or like some sort of therapeutic session before they walk back out that door?
Reiki's the answer for everything.
I do. I love Reiki. I think it's so incredibly powerful. But it would.
Do you know? Not to interrupt you, but do you know that I got Reiki done in the cardiothoracic ICU?
You did.
My nurse, one of my CTICU nurses, was trained, certified in Reiki. Yeah, amazing. It was amazing.
I loved. Obviously did not have the experience you did, but I was struggling and had Reiki as well, and I couldn't believe it changed the outcome of who I became as a mother after that moment. And I think some people are like, "How could that possibly be?" Once you experience it, you're like, wow, it is life-changing. Yeah. So yes, that would be my approach in the hospital. There needs to be doctor, nurse should get
a real checkout though. You are not here anymore for the 10 minutes that it takes to do whatever nice thing we're going to do for you, because that's, you can't really ever check out. That's the problem.
No.
Yeah. You're always on. So thank you for that. Anything else? Yeah. What was your other thing?
Okay, the other two are tied together, which are, I asked my community who had experienced birth trauma, so this is more on like the mitigation aspect, what is the one thing that you wish your team had said or done for you? And far and away, like 90% of the comments, and there was 550 comments, 90% of them included acknowledgement. I just wanted acknowledgement for what I had experienced. I just wanted acknowledgement that was not normal, that losing 5 liters of blood was terrifying, that it's okay if I am not okay. And then the second most common one was debrief, because people are leaving the hospital having no idea what happened to them. And I understand that sometimes there's some like medication issues and like trauma memory and all of that, but that's why my argument is that like we should be debriefing early and often, and it doesn't have to be like an official hour-long debrief every time, but like right when you think the patient is good to go to like hear what you have to say. And arguably, don't get me down this road, but when it comes to ICU psychosis and ICU delirium, I would argue that someone should be telling that intubated patient every single day 2 sentences. Kaylee, you had an amniotic fluid embolism. You are okay. Your baby is okay. You are in the ICU at Lincoln Medical Center. Every day, someone should have said that to me. Yeah. Would I have remembered it? I don't know. It doesn't matter. But I thought I was in a horrific car accident and that my son and husband had both died, because that's the only reason my brain could figure out why I would be in a cardiothoracic ICU.
So like how grounding to have that factual information.
And reorienting, which is part of treating ICU delirium anyway.
Yeah. Exactly. And so, and then at the end. So the one that I feel like people cannot miss is when you are discharging that patient, they're going to be the most possible sound of mind. So you need to give them a debrief on discharge. That is like, in my opinion, one of the most important ones.
Right. Because when you're still kind of going through it, and I know too from some traumatic thing that I experienced, you might think that you asked all the questions or that you had an understanding, because there's just, you're in this different mode, this different mindset. Yes. And then you come back and you're thinking about this later and you're wondering, I didn't really actually get a full explanation of that. Or I had these other questions. So early and often on discharge, and then probably allowing, if you're getting a debrief, okay, what's the follow-up? If more things come up for me, what is the process for that?
Yes. Who's the contact?
Who is the contact? And, how quickly will this happen? I'm not waiting for my appointment that's weeks and weeks away or whatever it is.